isn't going to cut it anymore. And I think it's beautifully illustrated by Charlie Chaplin. So I'm going to show, if we have the sound back on, I'm going to show you a Charlie Chaplin film that says it, I think, better than my words will. So hands up if that feels like work. It's a fairly universal experience, isn't it? Here's the thing that we've got to unlearn. In the NHS, we've got used to doing things differently, and we've got made massive strides every year in the NHS, but an awful lot of it has been to do with more. So we've got a new thing we've got to achieve. There's a big challenge or a big opportunity. What we ask for is more, as though that's always enough. I think we're at a state in general practice at the moment where just more of the same isn't going to cut it. We do need more money, we do need more doctors, we do need more nurses, we need more of all sorts of things. Many of us need bigger premises. There's a lot of more needed. But just doing more of the same misses the fact that we need some qualitatively different things. We do need to improve what we do. We also need to do some things differently. We need some different people doing things differently as well. So I think we need to quash the notion that just having more of the same is going to be the answer. That sticking with the way we're organising our practices, sticking with the way I do my daily work, I think isn't good enough. I think it'd be unethical for us to ignore the fact that we need to do things differently and do different things, as well as making the case for saying we need more. And that's why I think people are talking about so much change. That's why people are talking about so many different kinds of changes. It's also why I'm really pleased at the approach that's being taken in so many of the Challenge Fund pilots, yourselves included. And I'll highlight some of the similarities between what you're doing, what other people are doing in just a moment. I'm conscious that we've been sitting for a while, so I wonder if we can do a small little exercise. If you're able to stand, would you stand with me for just a moment? And I'm going to ask you, please, if you could point to north, please. So got a few moments for everyone to orientate themselves and point to north. Who's? Okay, hands up who's cheated. Okay, would someone who's cheated like to tell us the actual answer? You have
I haven't got the glasses on. It's this way.
Okay, the official answer is it's this way. So well done if you were vaguely correct. Do have a seat. Thank you. So it wasn't just sort of a bit of physical exercise and frivolity. It was also an opportunity to say let's look forward. I want to share thoughts about three things. The first and far most important is what kind of care people at the moment are looking to deliver for the communities they serve. A couple of thoughts for those of us who are doctors about some of where I think the implications of that might be. And then finishing off with some thoughts maybe to correct some assumptions that many of us have been working under about federations of GP practices and stuff like that, what kind of organisation. So if we think first about what kind of care. I mentioned earlier this call to action on general practice, and this was a really interesting thing. I was invited to come and start working for NHS England 2 years ago to help with this thing, and we went around the country asking people, what are you working towards, and what the challenges are so far, and what you think the NHS kind of corporately could do to help you get there. And what was really interesting was just how similar it was all over the country, whether you were in the middle of a city or in the middle of nowhere or somewhere in between. People were describing a desire to have much more comprehensive care, much more joined up care, but really emphasising the strengths that we've got at the moment in general practice, that you belong somewhere. You're not hopping from one hospital to another hospital hoping someone will care. You belong somewhere. There's a team who looks after you. And then as you kind of boil down some of the specifics, a lot of people were talking about moving from just providing medical treatment to a focus on helping people stay well as well, and kind of partnerships with local authorities and things like that. A lot of people were actually, even 2-3 years ago, doing stuff on improving access to care and just general practice. Lots of people saying we've got good care, but we've got a lot of variation still between practices, or between, some issues we really struggle on. And then lastly, lots of people describing this very different paradigm of care for people with long-term conditions, saying let's be proactive, not reactive, let's be holistic, not just medical, let's work as a kind of a system and a team around the patient instead of working in different silos, and we'll never collaborate because we're in some bizarre battle between ourselves in the NHS. And the last thing was that underpinning all of that was a thing we call people working to provide wider primary care at scale, so greater collaboration and greater size that people were working on. And it was really interesting seeing how consistent that message was from everywhere around the place. And so we started trying to gather this list of specifically what it was people were doing to sort of realise those visions for the future. And here's kind of 3 lists of those, slightly randomly presented. So paramedics with practices, minor injury services, phone first, pharmacy, physio first, consultations on the web, don't have to phone in at all, just put your symptoms into the computer, community-based diagnostics rather than travelling, primary care-led urgent care centres, a lot of things in there. You are doing some of them, lots of other people doing them as well. Next set of lists was this, to do with kind of collaboration and boundaries. So direct access to specialist advice, contingent management training, helping people take care of themselves more, coordinating care, sharing records of virtual wards, so rapid access support at home, in reach to hospitals, kind of reaching out to care homes, lots of stuff about breaking boundaries between people. Also lots of stuff about going upstream, people call it, not waiting for people to get ill and then catching them, but actually helping more people stay well more of the time. Loads and loads of stuff happening all over the country. And what I think's great is seeing how well reflected that is in Challenge Fund work. Acknowledging that partly some of that is about access. It's not just about quick access to the same old, it's about getting right access, right time, right place, right person. A beautiful illustration someone gave to me of it about 1.5 years ago was this. They actually described this, and I managed to find a photograph of it. They said sometimes we've improved access to make a really nice shiny door, really nice route in, without asking what you've got to route in to. And so I think it's great to see all the stuff that's happening. Let's unpick that in a little bit of detail. I'd like to share with you some of the detail about what people are doing around the place in the Challenge Fund. The 2 big headlines are lots of changes to the kind of care people get, but then also lots of changes to the underpinnings that enable that to happen. Lots of organisational stuff, lots of business stuff, lots of information stuff, without which all of that is incredibly difficult. But if you did that on its own, it might be a bit purposeless. And sometimes we've tried to do that without that, and sometimes we've tried to do that without having a clear purpose. What's great is, and I think we've already heard this evening, what you're doing here is much more meaningful, because you're describing what you want to achieve for the people you serve, and then you're being really clear about what kind of infrastructure, what kind of organisational changes are going to be needed to make it happen. So the stuff people are doing, as you look around the country, people are doing things like extended hours. Evenings, weekends, speaking to folk from Milton Keynes recently, big commuter population, they're not doing evenings because no one's home in the evenings, they're doing early mornings. So a lot of it is really important to adjust what you do to what local people want. And if you read, as you will undoubtedly read, yet more stories about the failure of local GP practices who are closing all over the place, brackets because they're providing fewer doctors on a Sunday afternoon. That's a good thing. It's a sensible thing. People are realising that what their local people need isn't necessarily the same all the way through 7 days of the week. And they're adjusting it according to local needs, which is exactly what we've been encouraging people to do. So each time someone phones us up and says, do you want to comment on yet another failure? We go, yeah, of course we do. It's a brilliant idea. Because that's what people are doing. They're adapting to meet people's needs locally. But they are also trying to reshape that demand before it gets to the GP, because not everything needs to be seen by a GP. Some things can be better met before the person gets there. So you are doing stuff around pharmacy, work in pharmacy, other people doing stuff around going into schools, doing health promotion, the use of pest to power to help families, and particularly families who aren't used to westernised healthcare systems and aren't used to general practice, haven't a clue what a general practice is, who assume if you're ill you go to the hospital, then actually it's really helpful doing that pest to power in schools. A lot of people are trying to go out to where people are and signposting them. So some of the apps and the portals and the things that are out there are doing that, and they're saying, what's your issue? Let's try and connect you directly to the best way of meeting your issue, thinking about appropriateness. Once you get in, lots of people are then doing what I'm currently calling the active front end, which sounds a bit techie, and someone really had to go at me this morning about saying it, so I apologise if you don't like the term. But the idea is that whether you come in person, or you phone up, or you use the app, or you go online to a web portal, actually there's an active engagement about saying, how can we best connect you? So it's not just you having to make up your own mind. We'll give you suggestions, we'll find out what the issue is, what's wrong with you. If actually we know you already, why don't we connect you with a care coordinator who knows you well and can say, oh yeah, sure, no problem, you need to speak to Janet, she's in tomorrow morning, I'll get her to give you a call. Rather than this assumption, you're ill, you must see the doctor. Much more active engagement with the person to say, how can we best help you? And that's particularly helpful for people who actually provide most of their care themselves. If you're one of those people with multiple long-term conditions, you are your chief expert, you are your chief caregiver, and so some of what we need to be doing in this active front end is building people's knowledge and their skills and their confidence to look after themselves more of the time. So a lot of what people are doing, when you look then about contact modes, is sometimes using those web systems, those apps, or text messaging to say, okay, text in your peak flow if you've got COPD and your breathing problems, or text in your weight if you've got heart failure, and the system will remind you. So if your weight is going up and your care plan says if it goes up by this much, you know you need to take an extra one of those tablets, we'll remind you, we'll build your confidence to do it. If you're feeling unconfident, phone us and we'll deal with you straight away, but you could do this more of yourself. So a lot of what's being done here about diversifying and phone and video and text messaging and online apps and things like that, it's not just about taking time out for GPs. It's not just about the fact that in our practice the average phone consultation is 4.7 minutes and the average face-to-face consultation is 12.5. So actually if we can deal with it on the phone, that's more time we've got to spend with a person who needs actually 25 minutes. They can have 25 minutes because other stuff's been quicker. So it's not just about making life easier for practices, although the pressures are such that we have to make things easier for our practices. It's actually quicker for the person as well, it's more convenient for them, and it gives more opportunities to connect people to the right stuff. Lots of people are then actually looking very much inside the practice. And again, I don't think this has been always very obvious to folk, but redesigning how we match capacity and demand during the week to reduce queue formation, to reduce hassles, to make it easier for people to get continuity of care if that's what they need, is really important. It doesn't just happen. No one can do it for you. It takes a bit of skill. It takes quite a bit of measuring. But actually redesigning our appointment systems in hours is really important, partly to improve access. But if you can improve access by doing that, you also make it easier to get continuity of care. We massively, I think we tripled the proportion of our long-term conditions patients who were able to see their usual GP by redesigning our in-hours appointment system. We didn't have to make the GPs work longer or be available 24 hours a day. We just reorganised our work. Next thing is, people are acknowledging, I said one size doesn't fit all. Some patients do need this rapid access care. And some patients actually need almost anything but. They can wait. Waiting's absolutely fine as long as they get the right person doing the right thing. Lots of interesting stuff in this rapid access thing. Lots of people are doing kind of using nurses and pharmacists in the practice to provide minor illness services. Some people, particularly with a lot of children in their area, are doing an afternoon clinic, the sort of come home from school clinic in the afternoon, sometimes entirely in the practice, sometimes with paediatricians or paediatric nurses, depends on the needs. Some people are actually saying, no, we've got a lot of housebound people, and the problem there is everyone waits until lunchtime or waits until the end of the day to get a GP visit. And the big problem about that is if you go to A&E, if GP visits you and says you're really sick, and you go to A&E sort of after about 4 or 5 o'clock, you are staying in hospital overnight. It's guaranteed. Whereas actually, if you phoned up at 9 o'clock, well, why couldn't we share a GP amongst our 50 practices around here? We could have a GP round to you in half an hour, an hour. If you need to go to hospital, you can much more likely get dealt with in the same day. So some of that stuff people are doing as well, and some of people are blending all that sort of stuff. And then, as I said, a lot of people are saying, how can we be more proactive? How can we be more coordinated? How can we build a deliberate partnership with our district nurses, with our social workers, with the housing advisors, with the voluntary sector, people from Age UK or the Heart Foundation or the Alzheimer's Society, who could support you far more appropriately than a GP with a prescription pad could ever do. But often if we don't ask the question, it won't happen. If we don't look ahead, it won't happen. If we don't help people join up and work as a single team, it won't happen. And a large part of that, obviously, is broadening the skill mix. Not just a doctor in a consulting room with a receptionist anymore. We've been moving this in direction for a while. I think we're seeing people go exponentially upwards in terms of the diversity of the skill mix at the moment. And that's partly because there aren't enough GPs in this country. And even though the government is committed to training more, it's getting really hard to fill those training places. So actually, with the best will in the world, it's going to be years till those new people are available and working in a surgery near you. So even if we had the luxury of just saying, okay, fine, let's magic 10,000 GPs from somewhere, it's not going to happen. But even if we could, it's not the best thing, actually. We probably don't need just to double the number of GPs. We need to broaden the skill mix. People are doing that in the ways that I've talked about already. But all of that has some big organisational stuff that's necessary to make it a reality and to underpin it and sustain it. So lots of people are working in big collaborations, and the size of collaborations in the Challenge Fund varies massively from 2 practices to nearly 400. So it's quite varied, but it's all about getting more together and doing some things that a single practice simply could not possibly hope to do, whether that's to do with a rota or new staff or new information or a new partnership. How can we expect Age UK to have 27 meetings with 27 practices to plan what they're going to do? That's why it's been so hard for so long. So working at scale. Lots of people are using the Challenge Fund as an opportunity to free up staff capacity in general practice. And I think if we don't do that, then there's a risk that all of this is just about working harder. And I don't know about you, but I don't know many practices where staff could work that much harder. So freeing up time seizing every single opportunity to take some waste out, or to find someone else who could do this, or to find a more efficient way of doing it. Every single appointment you can save, every single 5 minutes you can save makes a huge difference. Frankly, some days if I could just get to the loo during a morning surgery, I'd be safer. So every moment counts, and I'm really encouraging people to look for as many opportunities as they can to do that. That sometimes takes some expertise that we don't have in general practice. It sometimes takes someone from the business world who knows about lean, for example, to find an opportunity to improve productivity. Being a doctor, my first response always is to jump in, to have a go, to work harder. Actually, sometimes the managerial perspective and some of these tools like lean are what's necessary. And then loads of stuff people are doing on sharing hubs and co-location. Masses and masses of work on IT, not just for the benefit of the practices in terms of sharing, not just for the patients and their carers, but actually for the whole system. We're so much at the heart of it. If we can be part of the revolution in IT in the NHS, it will help everybody wherever their starting point. And then a lot of people are doing huge amounts of work on developing workforce, training, recruitment, and that sort of thing. As you look at that, I know that you've got a heck of a lot going on already in those boxes. It may be that some of your practices aren't fully grabbing hold of the opportunities that this presents in terms of the amount of space and time and money that people from the world of IT that we're commissioning to help, people from the world of lean and service or leadership development who could be helpful. Some practices really are, but some may not be. Some may be thinking, well, this is all right, but it's just about that. I think it's not. Your work is not just about extending hours. It's about something far more meaningful as well as extending hours. But I think it's really helpful to see the big picture and kind of learn that this stuff isn't just hypothetical. The incredible thing right now